We know there are challenges for employers in the market. From market trends to interviews with industry leaders, let us be your trusted advisor as we explore the benefit summary, presented by Genesis Health, with your host, Matt Monahan.
Miro, thanks for coming in today, man.
Thanks for having me.
Nothing like starting a podcast when right before you go on camera, someone's like, "Oh yeah, I didn't read your questions."
I also didn't know it was on camera, so there's also that.
We are now. We are being filmed. I don't know if in the state of New York we have to legally disclose that, but we are definitely being filmed. But no, I'm psyched you can make it and brave the cold. It's freezing out there.
Yeah, it's luckily it stayed warm on the way here.
I was so jealous of you, Jack. I would love, as we kick this off, and give you a brief introduction to CEO of Radish, but love for you to just kind of tell us a little bit about your background and how you got here.
Yeah. So my background, I wanted to grow up to be a doctor. I didn't think I'd be in this position at this point in my life. I went to med school. I actually went through residency, practiced at a pretty high level. I used to be the vice chair and director of NYU's Brooklyn Emergency Room for a little while, and then saw a lot of interesting things happening in health tech. Had no tech experience, so as normal people do, I quit my job and tried to figure out something in health tech. Landed at Oscar, grew in from initially just a consulting role to a medical director, where my job was to help bring in-house what used to be farmed out to Teladoc. And learned a lot in the process. And I think it's like taking those two experiences, as well as just being the doctor for my friends and family when they'd call, is what led me to create Radish. I'm sure you'll ask that in a bit, but I'll go ahead and say now. Really, our thing is that I think a lot of people in the healthcare system are confused on what to do when they get sick. And certainly they have no clue what to do before they get sick to prevent that from happening. And who that historically has been is a primary care doctor. And a lot of people don't have that anymore. And I think with digitization of healthcare and a lot of these like point solutions showing up, they do single things really well, but they aren't owning the whole process. And that's where we want to get back to having that relationship with your doctor that you can always reach out to. And that's what we're trying to build.
And I think when you look at that from a doctor standpoint too, it's kind of like a digital version of like what the movies used to be, when like the doctor would come in with his bag and show up at somebody's house and treat them, right? Like there was an actual relationship there. Did your time as a doctor kind of help shape how you wanted your patient experience to be as a CEO of Radish, like how you want to bring that to market?
Yeah, I think a lot of that, especially as an ER doctor, I found that most of our visits, when I spent time with patients, you had about 15 minutes to talk to a patient. And usually the first few minutes, you're just trying to feel out the patient and build some sort of rapport with them. In our case, I didn't know the patient from before. So you're trying to build trust and a relationship with that patient. Then you have the next 5 to 10 minutes collecting data on questions you're asking them, whether it's examination findings, blood draws, etc. By the time you get to the important part of the conversation, which is what the hell is going on with you and what to expect, you're, as a doctor, like you're being pulled in another direction. How we think about our product and how we think about providing care is like, how do we remove a lot of that stuff on the front end so the doctor can get to the meat of the conversation? And I think, to your point, the old school doctor, with a little bag that shows up, the thing that we always say, it's like with Radish is like having a doctor in the family. The same idea. When my friends and family call me, I'm not looking up their insurance information. I'm not looking up their prior medical history or allergies. I know it, right?
Yeah.
I get to the answer. I ask a few questions and I get to the answer that they're really looking for. Like, do I need to do X? Like, do I need to go to the hospital? Do I need to go to a specialist? Do I need to do nothing? Usually it's nothing. Spoiler alert.
The family of hypochondriacs.
Actually, no. There's a running joke in my family: never call Vero when you're sick, because they'll just tell you you're fine. I'm like, you guys are all fine. Turns out you're fine.
I love that. So I'm not calling when I'm sick. No, but that's awesome. I mean, I think we've worked on a number of different things together, but as we build, our business, one of the things we look at is having the clinical quarterback. And a lot of that was the ACO model that was built over the course of the last decade. But like where that failed, I think, was that doctor worked for one of the facilities they were trying to then drive you into. And I think that's one of the biggest challenges, as opposed to something like this, where you have an independent physician giving you an actual opinion who's going to try and drive you somewhere that, where you're supposed to go, or give you a reason as to why.
Yeah. And it's funny because that you mentioned that. So hospital systems don't buy primary care practices because they generate a lot of revenue. They buy them as lead gen. Right. And that those are the people that they're continually asking to send them to their hospital for specialty procedures and for specialist visits. So my friends complain all the time when they go to, a system affiliated practice. Like, I go in there, I just get 3 referrals. I didn't even ask for a referral.
Yeah.
Like, I'm just asking for care for what I need. And they're trying to do it right, but the KPIs for hospital systems and when they buy practices, like, how many people are you sending to the main center where we generate the most revenue?
Yeah. And the incentive is there to drive them there. And like, it's also how they're contracted to your point. Like, they're getting the underwater physician's office that's then driving people in. But like, and even at the reduced unit cost that they're saying that they're going to work at, that unit cost is still, at a money making point, and you're still driving volume into it through those facilities that they're purchasing. So
Right.
yeah, it's such an interesting, having been a part of launching those, I fundamentally believe that having the doctor drive the care is super important because you need someone who knows what they're talking about, who understands why you're sick, and can tell you, is this a real thing or is this just something that will pass in a week, or do you need antibiotics or whatever? But also just as a means of keeping people out of the emergency room, which
Right.
is just true episodic care in a very small window with someone who has no idea who you are and won't know who you were tomorrow.
Right. And I think it's not just the doctor quarterbacking your care, but the doctor's financial incentives to be aligned with yours or more
Yeah.
closely with yours, not the system they work for.
Yeah.
Because they're getting pressure in both directions. And I'm not saying doctors are terrible people. I was in that position. I think the system is set up for them to get pulled in two different directions.
Yeah.
And they're trying to do the best they can. And I think the doctors that we work with, we talk about that all the time. Like, how do we make this a practice where the doctors can just provide accurate medical care and help people, as opposed to having to worry about how many people I'm sending to specialists and how many people are getting other procedures.
And I think it's funny how you said, like, our practice, right? Because you're a medical practice. And I think that gets lost in the sauce sometimes with this like comment of like telemedicine.
Right.
I think when people say telemedicine, they're like, oh, it's just a doctor who's going to like, see me, fix something and, move on.
Right.
And you're creating a virtual primary care doctor's office,
Yeah.
in a different format.
I think the closest thing that I could come up with was telemedicine as it exists amongst the other telemedicine players is how you use an Uber or a taxi cab. You don't know your driver. Frankly, you probably don't care. It's been commoditized to where this thing takes me from here to there. Whereas with us, it's the Upper East Side person that has their own car and their own driver, and that person picks them up in front of their door. They keep their stuff in the back. They're not trying to like take their luggage in and out of the car. It's always there.
Yeah.
And I think that's the closest comparison we can come up with. Is like that's the level of service we want to provide, is not building that relationship every time.
Yeah, I agree with that. I love that analogy too. And as two New Yorkers, like we totally get what that is.
Yeah. My 18-month-old, one of the first things we taught him was my wife taught him, it's like, whenever we say taxi, I'm like, taxi. So I've yet to actually get him to call a taxi, but we're gonna try it soon.
No, they do. It comes like
Yeah.
my little guy will stand next to me, like I'm like pulling him back so he doesn't get hit by a cab.
Right.
I'm like, buddy, you want to call it, you don't want to die by it.
Right.
So, but yeah, it comes. They figure it out. So, I would love to understand too, like over the course of COVID, right? Like there's been a lot of different studies, but the Journal of Primary Care and Community Health posted findings that virtual primary care was up 35% from the pre-pandemic to post-pandemic, or even like mid-pandemic. So I would love your thoughts on how this market continues, because it will, I believe, and I think there's an investment from not only people like yourself, but even hospital systems are trying to drive percentages or larger percentages of some of their specialty services into like a telemed. But how do you see the market evolving over that span of time, and what do you see like the growth opportunities? Because there's a lot of them, I think.
I think that there's a lot of things that don't need to happen in a doctor's office that still are. So there's a massive amount of things that you don't need to see your doctor in person for. I think you'd be surprised by what percentage of things you can take care of virtually with some additional tools, right? Like
Yep.
there are limitations to telemedicine. I think that we can't forget that. But most follow-ups can happen via telemedicine. I don't
Yeah.
understand why doctors bring their patients back to the office to tell them their labs are fine, which happens all the time.
Yeah.
Right. Or bring their patients back to the office to talk to them about their, echocardiography results or their cholesterol. Like, just, you can call them.
Yeah.
Right. And it not only is it cost effective that way, but it's also just a better service because you don't have to schlep yourself to the doctor's office. And we're seeing it amongst our patient base. A lot of the follow-ups we do, they like it because not only do we do them synchronously, if we want to do video, they can also do them via text message.
Yeah.
And it's really nice if you have other responsibilities, a job, children, school, trying to pick them up, drop them off. And now you're trying to manage going to the doctor's office for a follow-up, and you spend an hour and a half doing it when it's 5 minutes FaceTime with the doctor.
Yeah.
Which is absurd as a patient experience.
Well, even as an employer, right? Like I think of it like in terms of like selling this product with an employer, it's one thing for your employee to go to the doctor. It's one for them to have like multiple follow-ups that could have been done at a computer, home or in the office. And now
Yeah.
a lot of people are in this virtual, hybrid at the very least,
Yeah.
being able to do that. But I mean, living in the city, with the traffic trying to get across town to do something, like just the idea of having to go to a doctor for a second time
Right.
to have that conversation, I understand there are certain conversations that still need to be had in person that are more serious, but like I think what we're talking about is that like acute episodic care,
90+% of things I think can be done virtually, and a lot of those can be done via text message. Sure, the delivering bad news and some of those things that we're talking about, those are really, really rare
yeah.
situations. And I think, of course, those need to happen in person and need to happen in a way that you take your time. Those are not 5-minute visits either,
No,
right?
that is true.
You're not going to complain to go across town and get childcare and to get that
Yeah.
sort of news, and your doctor took the time to sit down with you for 35 minutes to an hour, right?
Yeah, I agree. I think like having seen the numbers, like my first reaction was, 35%, above like, almost zero is not that big, but I think it really speaks to one, I think there was a lot of things that went digitally, so it helped accelerate. So I think people got more comfortable working with a Zoom or one of the telemedicine, one of the, teleproviders,
Right.
and so I think that helped. But also I think it just like people started realizing like the amount of time they got back. And that wasn't just telemedicine, that was just like telecommuting and doing all that stuff. And the time gained, I think, is something people aren't looking to give back at this point. I think,
Yeah.
some of them are starting to commute again, so that's going to be lost time. But like, there's going to be things they're going to be looking to not travel for if they don't have to. And I think that's part of like the tailwind of this is getting that opportunity. But in I also look at this like, do you see as like you build Radish, like there's going to be other services you build into this?
So right now, we our two main service lines are virtual primary care and mental health.
Yeah.
So we do have therapists on the platform as well. And the mental health initially, we tried it out about a year and change ago as a pilot, and it worked really well. People enjoy the aspect of virtual mental health, and that most of the folks that we got were saying, "Man, I've wanted to talk to someone for a while. I haven't been able to figure out how to find someone in network, and more importantly, I just don't know where to go."
Yeah.
That was one of the big buckets. And the other one, we're getting people that had a stigma around going, and they're afraid of their car being parked outside of a therapist's office. So we're getting people that have been dealing with stuff for a really long time that's affecting them at work on a decreased productivity because of it. Their home life is in the shitter because of it, and they're able to talk to us in the comfort of their car on the way home from work,
Yeah.
right? Or on the way to work, which is awesome to see. And so obviously that's become now a core part of our product as we start to see those stories.
Yeah, and it's funny. I mean, I think when you start thinking about just even gaining access to care, I think, it's very, people have learned over the years, like, I know how to find a doctor. Somewhere in that, work to find a doctor, I can probably figure out how to find a specialist. But like mental health has been one of those situations. Well, one, like, it's not, if you're trying to find a doctor, and not that it's good or bad, but a lot of people ask, hey, the Viral, who did your knee when you went
Right.
to HSS, right? But like they're not like, hey, who's your psychologist?
Right.
Like you're not getting that question.
And I think the other thing, even if you did get that question, everyone's problem's different, right?
Yeah.
So there are sites out there that aggregate mental health professionals and what their specialties are, but it becomes cumbersome to try to figure out who to look at. Like you end up just like, I guess this person specializes in addiction, or they specializes in grieving, or whatever your issue may be. But if it doesn't fit into a box, it's hard to find the right person. So interesting, what we tried to do, and it's worked, is we actually just proactively assign you someone, and
Interesting.
then you talk to that person. If they don't meet your needs, or they don't think they can meet your needs on what you're coming to them for, then we'll assign you someone else.
Almost
So it
like a
removes
triage.
it removes that barrier, one additional barrier of trying to find someone, right? Because anytime you start to add work to people to get the care they need, they drop off. There's some drop off in each additional process you add. So step one, finding my insurance card. Step two, finding someone in network. Step three, looking at these people and then calling the people. Like maybe I call the first one, they say now I'm out of network.
Yeah.
Right. So everything you add, like they're less likely to get the care they need.
I like that. It's really interesting because I think assigning it to somebody also takes some of the stress of them having to like one kind of like go into the self-realization that I want help or need help. It's like, oh, I have this person, I should reach out.
Right.
It gives them like that one step, like one hint of freedom to be able to just kind of, yes, we're gonna move forward. And then I saw, one of the other things I had noticed that you guys had on your website was the nutritional services too, right? which I think is addressing a massive underlying need because I've read a number of different journals and you know e- at one point in this past year, the CEO of Hackensack Meridian talked about like the underlying health conditions, addressing those, but like some of those underlying health conditions are being driven by just like unhealthy lifestyle habits.
Right.
And how do we start fixing that? I think like all the episodic care, the mental health, if we don't address like the rest of the problem, which is health and nutrition, which I drove by something in Times Square today. It was like, you wanted, it was basically like a picture of like a whole bucket of sugar, like complete, like no health, nothing healthy, it like included or something like that was the slogan. So, I mean, like that's advertised on 42nd Street in Manhattan. Like I got to imagine like that's a massive problem. How do you fix that? Right.
Right.
And so addressing that in your practice has to be important as well.
Yeah, I think that so like with mental health, we started off nutrition as a pilot, and the initial goal was we thought people would come to it when they're trying to make life changes proactively, and they would talk to a nutritionist before they went on a diet. That's not what really happened, but interestingly, still has utility in that what started happening is when people saw the physician for the first time with us and they had never seen one before, they're diagnosed with prediabetes or prehypertension, or hypertension or diabetes, we started sending them to the nutritionist as a part of their overall
Yeah.
process of getting to not have to be on medication if that's what their goal was, or to augment the medication with lifestyle changes.
Yep.
So like with everything else, we try to keep it all together where like the doctor talks to the nutritionist who talks to the therapist. It's not three different people providing you three different types of care.
Yeah.
So that was a good surprise. Not what we intended it to be used for, but it was nice in the end that it showed real utility. So
Well, I have to imagine too, from the diabetes standpoint, because I think that and like high cholesterol is one of those things that sneaks up on people. And then once they're there, like, well, what do I do? Like, I'm relatively healthy. I run or I do, some sort of exercise, but I'm still seeing the levels creep. And like, that's either you start drifting towards medicine or you start drifting towards lifestyle changes or it just turns into diabetes.
right.
And right, like that's
Yeah.
the,
I mean, I think most people focus on weight because they
yeah,
can control it and they can't necessarily control it, but they see it every day,
yeah,
right? They can see how big their waist gets. They can see the number on the scale every day, but you don't check your blood pressure every day. You certainly can't check your A1C or your cholesterol every day.
yeah.
So I think that's why it sneaks up on you because you just don't know. And then all of a sudden now you're diabetic. Like what the hell happened?
I agree. It's such a cost driver. I think when we look at on our book of business, it's a $17,000 a year per person problem,
Right.
and beyond that, it also is just a very challenging lifestyle disease for somebody when you start having to then go into testing blood regularly. It's a big change, and so it's something that we look at to try and measure because that correlating with some of the other disease states, whether hyperlipidemia, hypertension, as better than I mean, you 7 more years of education on this than I do, but like those are things that if we can start controlling prior to them getting to meds, or at least with medicine, and get those things under control, it can have a direct ROI on the plan sponsor from a soft dollar standpoint.
Yeah. I mean, and meds are expensive. I was joking
Yeah.
with my wife. I'm like, you guys are, she's a cardiologist. So I'm like, you guys are single handedly bankrupting the American healthcare system. 5 of the top 10 drugs that are sold every year are cardiology drugs.
Yeah.
And they're all for high blood pressure or cholesterol. They're super expensive and you have to take them every day or multiple times a day. So in terms of patients coming back, right, it's
Yeah.
only thing like I think more profitable would be cigarettes. So
And it's funny because like I just mentioned ROI, but I would love to talk to you about like how you look at this from an ROI. So if I'm an organization trying to buy a product like this, and when we consult, we talk to them a lot about the ROI. But I'd love to get your thoughts on it, because there's a soft dollar amount which is like claim mitigation, and that's like I'm gonna take you have 100 diabetics or 100 people with hyperlipidemia or hypertension, and we're gonna be able to help either fix those. But like there's also the people that are pre-diabetic that you help avoid. But I think there's a true soft dollar claim mitigation, and there's definitely an ROI on the hard dollar. Like for each event that comes out of the ER or that comes out of the hospital, that goes back to a virtual care, or comes out of the marketplace and goes to a virtual care. What are your thoughts on that as far as like how someone should be thinking about the ROI? Because both numbers are, I believe, relatively large, and we've seen that on our book of business, and I'm sure you've seen it on the companies that you're working with. But I'd love your thoughts there.
so I think that we start like the first, it's a better experience, right? So I think the simplest ROI to show to your employees and staff is that you care and you're providing them a better service. And will that lead to more employees staying on, less churn on your employees, and then staying healthier? Now to get to using the system less and talking about how $1 spent on preventive care, I think saves 13 in the future. Now, you may not see that in some companies. The cynic in me will say, well, if you're spending $1 today, that person that is going to not become diabetic because of that, that's going to happen years down the road. They're no longer going to be working for me anyway, so it doesn't really affect me. So fine, we can leave that one aside. But there are claims that happen today. Something as simple as, you call your doctor because you twist your ankle playing softball, and they're like, if you can walk on it, you can probably just wait till tomorrow morning and I'll call in an x-ray for you.
Yep.
That's a couple $1,000 savings today. That's not preventative care. That's just having access to a doctor that you can call saved you thousands of dollars today.
Yep.
For primary care. So I think there's a lot of different ways you can look at it. And then obviously getting down to, if you save these things, then you're not on really high cost drugs permanently.
Yeah.
Right. And that's saving you dollars today as well. So getting people off drugs and then routing them to the right center are the best ways to save money today.
I also think it's like I look at the episodic care, specifically around the ER, and we've looked at different, because we always, through our data warehouse, we monitor our clients and, how they're running on a monthly basis with different KPIs, including the ER. But like, an average ER visit, say outside of Manhattan, but like, throughout the country, somewhere around 3,000 to 3,200. After the cost share, the plan's on the hook for about 27.5 or something around those, generally on average. And I started looking at those, like, because those don't have to happen. Or can I take, if I have 10% ER utilization, could I take it to 5? And, what does that look like? Because those are real hard dollars that you can measure. And when you start looking at like that virtual care visit, when you factor in, depending on how it's billed, that's 10% of the ER. And those are real claims that you can change tomorrow.
When I was a resident, I did an interesting study. Never got around to publishing it, but one of the things we wanted to look at is we saw all the time people coming to the ER for things that did not need to be in the ER for. There are kind of three big groups of people. They're the people that they really had an emergency. A doctor would agree it was an emergency. The patient would agree. Like everyone agreed this was truly an emergency. Those people should certainly come to the ER. We don't want to stop that. And there's the two other buckets of they came to the ER because it was more convenient.
Yeah.
Or they came to the ER because they were terrified and they thought it was an emergency, but the doctor did not. They thought it was an emergency. You're not going to educate people and give everyone in the country like multiple years of medical education to know as much as the doctor. So if they have access to a doctor, that can be a prevented visit.
Yeah.
And then for the groups that's coming because it's more convenient, that's a problem with the system, right? Like you can go to, there are places, I'm from Indiana, and like I see signs whenever I go home and I laugh, 8-minute wait time in the ER. Like it'll take me that long to get through the secretary for the primary care doctor, right? There's the reason why people are going to the ER and spending so much more money because it's easier.
Yeah.
Right. And like, the system is set up to do that. And it's easier because, and I did it when I was on the other side as an ER doctor. We had and every ER in the city has an area called like the fast track, or they have some name for it. Essentially, it takes care of people that should be going to a primary care doctor in the ER. And we create a whole department for it. It's a big revenue generator because you're seeing people, a PA or an NP is seeing people and cycling them through at 10, 15 minutes a person for something they should see a primary care doctor for, to the tune of $2,700.
Yeah, which it's funny because we went through that with my son, who he went like it felt like for like a year he was trying to set the record for most stitches attained in like different visits. And so, but I remember at one point like we got on with the virtual primary care doctor because it was during COVID, and I was like, listen, like he probably needs stitches. I just would love like somebody to take a look at this and give me like should I be looking at for concussions? How do I what do we need to do? And then if he needs to go to the hospital, take him. And we ended up having to go. We were able to, like, instead of go to ER, find an urgent care. They helped us with that. But I look at that and it was like, all right, well, that still was, $400 to the plan as opposed to $2,700 to the plan. In my experience was better because one, the doctor was like, all right, well, check if his eyes are dilating correctly and gave us a few things. And said like, yeah, he's getting stitches.
Right.
And then, we spent 10 minutes prepping him and we got there and he was happy to have a lollipop, like it was, but it helped.
And sometimes you actually can get better care doing it this way too, right? You
Yeah.
talk to the person like, yeah, he needs stitches, but it's in a weird spot. Like maybe you're better off finding a plastic surgeon. You can find a plastic surgeon that you take into the office, you'll get a better service in the plastic surgeon's office as opposed to that person having to come to the ER and do stitches on a child.
Yeah.
Right. So I think that it's not only it can be cheaper, but also just a better experience instead of you waiting in the ER for the plastic surgeon to come down from whatever they're doing.
Yeah, I agree. It's I think those are the types of things that when I start looking at ROI, those are much easier numbers to quantify. I think if I'm a CFO, those are things that like make sense to me as I buy these things.
Right.
And so that's where I think there's a huge opportunity. And I'm excited by what this brings to the marketplace, and kind of leads me to my next question, which was around Amazon, right? We saw Amazon Care launch and then close down, and I don't know, like launch within 2 years, close within that span of time. And I think to me, a lot of that was driven by, lack of market understanding, a lack of experience directed in this space, and how they were trying to scale that. But I would love to get your thoughts on how you see, Radish growing, and there's definitely headwinds just in like, we're still overcoming perception, that type of stuff. But I think there's a massive opportunity in this. And I'd love to get your thoughts on, how this goes, and, if you agree or if you saw anything else that like was a red flag for them that you've tried to avoid.
I think the biggest red flag that we've tried to avoid that they did was the home care component of it.
Yep.
By having it and pushing it, I think that was a costly part of the care they provided. It made it really convenient, but I think that's where they failed to really show ROI, because then it became really expensive.
Yeah.
So how do you think about maximizing care from the home virtually and using tools that are out there? Like, can you send people stuff instead of sending
So
a
send
physician
the cuff
assistant?
instead
Yeah,
of
send the cuff, not the physician assistant,
Yep.
right? I don't think they're quite ready for prime time yet, but there are home lab draw kits from various vendors that we've been testing out. They work well. I just don't know if people are ready to draw their own blood yet. We're getting head shakes here.
Romaine is not doing it.
I tried it. Obviously, I've drawn blood before, so I don't have a problem with like seeing blood, and it takes about 20 minutes. I'm like, well, it's easier to show to Quest, right?
Yeah.
So, but I think there's some interesting things out there that will be down the road. Hopefully, Theranos didn't set us back too far on home blood draws, but I think that there will be stuff coming down the pipe that if you can integrate to more and more of those things as they come out, that'll keep the practice cutting edge.
It's interesting because I like the I think there's some premise where like that virtual in-home stuff marries, but I think you have to scale one before you can scale both. And to me, it was like a footprint issue. Like we're gonna go launch in the 32 football cities. We're gonna build this thing out, and then we got to figure out how to navigate the traffic. There's so many components of that I think. One, I think you just need the base, and I think the virtual makes it easier, and it's a more accepted method. And I do agree with you, like sending the cuff, like things that people can do, the scale if you need to,
right?
That stuff, and having having a link or a direct link to different, whether it's LabCorp or Quest, where someone can go, which they do now for most of what they've been doing anyway,
right?
And that still keeps them out of going to a major facilities, blood draw, in paying the premium of going to the hospital.
Exactly.
So I think as long as you have a link to that, which you guys do, I think that still gives people the opportunity to do that.
Exactly.
But I think that's when it's in some of the conversations I've had, people have referenced that, and I said, like, like they to me, that failure was more a function, or the removal of them from the market was that the product they were launching, I think, was going down a path they weren't prepared to undertake. And I do think they're going to recalibrate and come back. But I think that's such an opportunity for companies like Radish to be now to gain the market share that was left behind, or the opportunity that was left in the vacuum that they created.
Right. And I think that to your point, like they went to a lot of cities too quickly.
Yeah.
And they could have maybe pulled off home care if they had some semblance of scale in one area.
Yeah.
Where the people weren't traveling over the whole city.
Yeah, I agree. And even when we had talked to them about like trying to navigate Atlanta as an example, I mean, I couldn't imagine trying to get a nurse across Atlanta to go, do a blood draw and then get back across to do another one. It would be brutal. And I like I said, I think the virtual gives it a much more, allows for more consistency. And I think you're able to create more redundancy in who the people are seeing. And, that comfort level is what's going to drive adoption in this, in my opinion.
The really cool thing that we've seen is we really push the idea of having the same person see you every time.
Yeah.
And you're assigned a doctor, you're assigned a therapist. They're your team. You don't get the next person up, like, the Uber driver situation that we talked about earlier. And because of that, people are using us more. They're like, oh, I love Dr. Sellers, right? Or I love Dr. Gandhi. Like, that's who I see all the time. That's my person. And not only are they seeing them in person, now they trust them enough to like randomly send them a rash. Like, I have this rash, and they send it in the morning. They're getting care much faster because they know their doctor, and they're quickly like just sending something to them. So I think we push more on the relationship as opposed to we'll send someone to your home at that sort of convenience. So there's various things you can kind of like push up and down and still
Yeah.
try to keep the cost low. I don't think you can do all of them unless you're charging a lot of money.
Yeah.
But we believe that the number one thing is that relationship and trust with your doctor.
I would agree. And are you seeing that from a repeat, like from a user survey standpoint?
And they're coming back.
Yeah.
Right? So there's 3 groups of people that we see employers who work with. Those that don't utilize healthcare never will until they get hit by a car. Like they're just not going to use this, right? And then there's the group that has a doctor, they kind of like them, but still hard to see them, but they still try to do it right. They try to go to their primary care doctor once a year, they get the refill from them, etc. That group will reach out to us when their doctor's on vacation or they get fed up because they try to call the secretary and get an appointment. They can't during a busy season. They'll call us, they'll see one of our doctors. They do that once, maybe they do that twice. And like, this is great. I like this doctor. They're just as good as mine. I can see them much more conveniently.
Yeah.
And the group that doesn't have a doctor or has had one but just doesn't really use any one person consistently and wants one.
Yeah.
Those are the easiest for us. Like they're looking for care. They're having a hard time navigating the system. We're proactively assigning someone. They use us and they stick with us.
Yep.
But we're seeing once people use us, they come back.
And does that go across demographics? So is that like male, female, or is that across age, or is there a certain breakdown where it's
the under 40 group far less likely to have a primary care doctor to begin with.
Yeah.
And even though it's like 50% of people under 40 have a primary care doctor, and of that 50%, they say they have one, but they haven't seen them in a year or a couple of years. So they don't really have a relationship. They tend to fit in that I don't have someone, I'm looking for someone bucket.
Yeah.
More. And then the over 40 crowd tend to have a doctor or have seen someone maybe in the last couple of years ish. Exactly. And they come to us after they can't find that doctor isn't available for something.
Yep.
And they slowly transition over.
Yeah. And it's funny because we've also seen on a lot of different clients, and we see it locally here a lot, was doctors converting their practices to be more exclusive and private. So it becomes like a membership organization.
Yeah.
And, we saw that with the One Medicals of the world and all those, but a lot of them also have had turnovers, retirements, or sales. And, what we talked about earlier, like, selling to the hospital system. And then it becomes a totally different experience than what you started with.
Right.
And that's another, like, I have to imagine you see a lot of that as well. But from an adoption standpoint, like, how would you judge like success? If you had an employer come on, tomorrow, we look back in 12 months and said, like, we had X amount of adoption or X amount of visits. Is there a number you're looking for when you work with someone, or is it going to be dependent on, like, we want to create the correct experience and the adoption will come if we create that experience? Or how do you view success in that scenario?
It's a question I've been trying to answer myself. So you don't want 100% adoption. That means your employees are sick, right? So it's a really hard thing for us to define too. And so we talk about all the time, like, how do we measure success here? If you have 100% of people using this in the first month, what are you doing to your employees? Like, what is wrong with your company? So what we try to look at is, like, we want to be available when they need to engage with us.
Yep.
And that could be for nutrition. It could be for mental health. It could be for primary care. It could be, hey, I just need to figure out how to use my insurance card, right? I've had a doctor. I need to see a specialist for this thing. I just need help. So what we try to do is we want to make sure that people create an account, log in, and are ready for when they need care with us. That can be on the ready anytime.
Yep.
So that for that number, the last couple companies we've done, we're like north of 80-90% within the first month. People are signing up, creating an account. And then whenever they need us, they can come back to us easily. So they're not looking for their insurance card when they're sick, or they're looking, trying to find the Radish app and find their login. It's already there.
Yeah. I like that view of it too, because that's a low pressure sale in that sense for the employee, right? It's just like, hey, log in. And if we look at like the amount of people who now know this is a tool, you're already, hundreds of yards ahead or 100 miles ahead of any other, I hate the term wellness, but like any other, auxiliary service outside of like the true major medical plan that they're working with. Most of them, if they're with Cigna, they're going to have some Cigna app, and they're going to know I have to go to my Cigna app to do something.
Right.
But for them to know that we have this other resource and we want people to use it for 80 or 90% adoption, that means 80 or 90% know that there's this enhanced benefit that's being offered,
right,
which is not being talked about on a daily basis. So for the fact that they have that and have done that, I think is a very good measure of success. And by way of people knowing about it, that's how you drive utilization. That, and I mean, honestly, the power of word of mouth in a company on a visit, and people aren't going to necessarily delve into what they had, but like the fact that they had hey, I spoke to this doctor, he was awesome.
Yeah.
Or you're not feeling well today, as a manager, you should call.
Yeah, I mean, like 99% of what we do is virtual, but for companies, when we onboard them, we will, on occasion, depending on the size of the company, actually send our staff to the workplace.
Yeah.
And all the time we see it. Like, one person will use us in the morning, and they'll go, half their department will come use us that afternoon. Like, oh, this is a great experience. Like, and that helps people sign up and get to know about us.
Yeah, that's awesome. It's funny how fast that goes, isn't it?
Yeah.
Like that word of mouth is just such a powerful thing in a company.
Yeah, you provide a good experience, people will come.
Yeah, throughout, like, department by department, like it just happens. That's awesome. Well, I think we've done a pretty good job here. I'm proud
covered
of
a
us.
lot
Yeah,
here.
we covered a lot of ground. Is there anything you want to leave us with on, like, thoughts on the industry, anything like that? I mean, I really appreciate you doing this with me.
No,
I
I think this is great. No, this is fun. No, I think that it's really important for us, and I think the industry in general, like, can we get physicians to be able to practice, to the max capacity of their license and not have to worry about their boss telling them they need to spend money in a certain way, and actually just provide medical care? And how do we incentivize those physicians in the same way the patients are and put them on the same side, and not have this constant battle of, I need to send you to referrals, or I need to, upcharge for this or figure this out. And I hope the industry moves in that direction, because that's, one, it's better care and it's better experience for patients and providers, but downstream it'll decrease the cost of care too. And I think that we can't continue to have cost increases in the way they have been for years.
Well, I mean, watching something go, up 50% since 2000, right, is not sustainable.
Yeah.
I mean, nobody likes the inflation now, but we've been living, 5 times worse inflation over the course of,
for
20
healthcare,
years for
it's been
healthcare.
doing
So,
that, right?
I think we have to be able to control that cost. It's just not as sustainable. And, listen, I mean, companies like you, like companies like ours, like Genesis Health, like companies like Radish, we are going to have to do that, to survive.
And I think that, it's really important for us to, and want to clarify here, that cost containment strategies don't have to be a worse experience.
Correct.
They can be a better experience, and just the right experience at the right time. I think in healthcare, the problem has been that the things that are profitable are what we've made really convenient, and you may not need those things all the time.
Yeah.
Right. So, like, the 8-minute wait time at the ER, it's not crazy for a person to behave in the system. I have this insurance card. I've been told by my employer that I should go to the primary care doctor, and I've been told by the world that's probably the right thing to do. But, like, I called the office. I can't get until next week. It's 8 minutes.
And I got to be honest.
Like, what are you going to do?
I don't think most employers are saying go to the ER doc.
Yeah.
Go to the doctor. I think they're just like, you have insurance, and like that's the box they check, so that, like, on the job description or whatever, they can say we are competitive with whoever else is out there. I think in this scenario, this is about, like, we're going to give you access. We're going to improve the experience. And we're hoping that through those 2 education points, we give you the opportunity to make a decision that's going to be more convenient, a better experience. And overall, like, if you engage, will drive better outcomes.
Yeah. I mean, like, I'm, as an ER doctor, I would say default, like, if someone comes in to the ER, you're going to take care of their unique issue at that time. And your job in that 15 minutes to make sure that person's not dying and they're okay to go home. That's that's the first thing you try to think of and figure out. And then it's like, well, make sure they're okay, and they'll have follow-up. Whereas if you're seeing them as a primary care doctor, you have the benefit of longitudinal care and for them to come back and see you. There is no follow-up with an ER doctor.
Still in the vein of, like, 1, they're not dying.
Right.
Then 2.
1, they're not dying. I don't need to send them to my friend in the ER, but I can see them again tomorrow, or they can call me tomorrow. And I think that's the big difference. In the ER, there is no, I'll see you tomorrow, right?
No,
you're not supposed to come back. Exactly.
Yeah.
It's who's next. They don't have time to have you sit here for 24 hours.
Yeah, it's like a deli.
Yeah.
Next.
Exactly.
But I appreciate it, Vero. This was awesome. Thank you for making the trip over here. This was fantastic. Thank you so much.
Thanks for having me.
Get more out of your benefits when you connect with Genesis Health on LinkedIn or through our website, www.genesis.health. And be sure to subscribe to the Benefit Summary wherever you get your podcasts. That way you don't miss the benefit of future episodes. This has been the Benefit Summary, presented by your friends at Genesis Health.